Welcome, everybody, to the Ramalinga Swamy Center's a colloquium series on equity and social determinants of health. We are very excited to have today Anant Bhan from Sangath with us today. He's been on our roster of people to invite for a very long time, and after much back and forth, we're really thrilled to actually have him here today presenting today's lecture. Anant works, as I mentioned, he works at Sangath. He works at their Bhopal hub. We usually provide the title of the speaker when, on the posters and when we introduce the person, but Anant is a man of many talents and it's hard to pin him down with a single title. He's been a researcher in and resource person for training in global health, health policy, research methodology, mental health, research ethics, bioethics, public health ethics, and more. And I think a lot of us have interacted with him or come across his work in many of these spaces. He has close to 2 decades of experience and numerous publications in all of these areas. He is a past president of the International Association of Bioethics and serves as an adjunct professor in Yenapoya, and is also guest faculty in various educational institutes in India and abroad. He writes regularly in mass media, participates in webinars and TV shows, and has been quoted in multiple news reports about a range of health issues and public health issues in India. He contributes to the medical, scientific, and ethics discourse via his participation in social media channels. He has a medical degree and a master's in bioethics from the University of Toronto in Canada. Very excited to have you here today talking about community mental health and the role of health workers in it. Thank you so much, Anant. I'm just going to send a reminder to our listeners to please share your questions as and when they occur to you in the Q&A box at the bottom of the screen. We will pick them up for discussion at the end of Dr. Bhan's talk. Thank you so much. Floor is yours, Anant.
Thanks a lot, Abba. Pleasure to be here today. Thank you for the opportunity to colleagues at the center. I've been following the colloquium series, and I was telling earlier Srilata and Abha that it's an absolute privilege to be part of the series because I think these are important conversations where I hope I will share something interesting, but I'm sure I will learn from the feedback, questions, and comments that you will have. So I think the topic that we ended up deciding on between Abha and me was sort of the focus on community health workers and what role they can play at the heart of mental health and mental wellness in our community settings. And here I would like to maybe start by saying that my definition of community health workers and wellness will be probably a broad one. While I'm going to give examples of work we've been doing with formal workers and informal workers in the health space. This could actually be extrapolated to any kind of community worker or a community activist or someone from the community who is very enthusiastic about contributing to wellness within their settings. And maybe that would help us enlarge the scope of what we think about when we talk about community mental health. So this will build on some work we've been doing. And of course, I would like to acknowledge the work we've been doing with community health workers, with various collaborators. And I think it's a reflection of what we have learned from them that I'm going to try to represent today. And it's much more them than me that you will probably hear about. So many of you will know that this is an issue which has gained limelight, I guess, more during COVID and post-COVID. But it is also something that we are well aware of, that we have a fairly high mental health burden, and that sometimes gets underrepresented in our mental health services, in the services on the ground, and also sometimes in awareness and investments in the public health sector. And just in terms of global data, also the fact that most people, around 20-25% people globally, will at some point of time in their lifetime have a mental or substance use disorder. And a fair bit of the global burden of disease is actually constituted by mental and substance use disorders. The fact that we have a huge care gap where only probably 1 in 10 persons receives timely quality mental health care, which they might need at a particular point of time. So almost a 70 to 90% treatment gap is something that we should worry about. And this was also something which was picked up by the National Mental Health Survey in 2016. The next survey is actually going to be released probably in a couple of years. It's ongoing right now. But even in 2016, clearly indicating that there is a fairly high burden of common mental disorders, especially depression, anxiety disorders, and substance use disorders. But also equally, the fact that there is a lot of stigma around mental health, and that does impact the ability of individuals with mental illnesses to access work, or to even be able to get education, etc. And that stigma is also a reason why many people don't report early enough when they have complaints associated with mental illness. And of course, this also has an implication in terms of the disability that they might have, because that's a form of usually invisible disability. And this disability can extend to their work life, their social life, and their family life. And as we know, out-of-pocket expenditure can be a significant deterrent as well as a cause for people to go into financial precarity, and that's also true of mental health. This is at a time when, of course, we have some specialists available, but not enough, considering the burden. And the specialists are largely psychiatrists and psychologists. And there is an acute shortage of these individuals. They are largely located in urban centers, mostly in private care. And this, of course, can be a challenge for then ensuring that mental health care, especially quality mental health care, is widely available. So, given this, we then need to figure out how is it then that we can respond to this challenge of the need for quality mental health care, which is not existing right now. And this is at a time when even international organizations like WHO indicate that the focal point where mental health should be provided should be largely concentrated on primary care or primary healthcare services. Whereas what we see is mostly location of services and individuals who can provide care in secondary care and largely tertiary care, right? And also in largely urban centers, as I mentioned earlier. And that is something which is hence a problem. So then what are the kind of innovations which can help respond to that, right? Now, and I will give a few examples, some of which will be examples where I feel while the idea here might be a good response to a problem, it's also a problematic approach, right? And these are probably examples of that, which seem almost like a band-aid approach. So in Rajasthan, as you will see on the top left corner, when they saw that a lot of women were dying by suicide by jumping into bore wells, they decided, well, how do we respond to that? Rather than responding to gender and equity considerations and patriarchy, which might all be playing a role, you cover up the bore wells by cementing them, right? And so you see an example here of what they did. In Kota, which also we have heard a lot of unfortunate loss of lives due to suicide, many hostels now are having these kind of spring-loaded fans where, if which is supposed to, again, help with addressing the suicide crisis, which we have in some of these institutions, not talking about the stress, not talking about the pressures, and the various other dimensions of why we have that kind of a crisis, right? So I tend to think these as being innovations, but perhaps not comprehensive and perhaps not the right ones. And many of you would have seen this whole discussion, which blew up a little bit. This whole example of IIT Kharagpur, which suddenly decided that we are also having these kinds of crisis incidents happen in our campus. So let's come up with this innovation of campus mothers. And that was, of course, rightly pilloried that, this is clearly not a well thought through step. And it is, again, not looking at what the determinants are, but thinking of mothering as some kind of a solution to that, which by itself, again, is problematic. There are also concerns that sometimes the way mental health is perceived, and this is also often the impression that mental health services and their design is based on Western constructs of how the science of mental health works. And this was a very interesting excerpt I read a couple of years ago, which talked about Rwanda, and this was, of course, in the post-conflict years, where there were a lot of concerns about depression, about post-traumatic stress disorder. And a community member speaking to a Western writer, Andrew Solomon, said that, when the Western mental health workers came in, they did not believe in being outside in the sun where you would feel better. There was no music, no drumming to get your blood flowing again. There was no sense that everyone could take a day off and the entire community could come together as a way of coping, as a way of responding, as a way of community building. Rather, what they would do is they would take us into a dingy small room, which was dark, and make us talk for an hour and talk about bad things which had happened to us, right? Now, I'm not saying that evidence-based psychotherapy is not necessarily a right solution, but clearly there was something missing from a cultural construct here, right? And how different cultural perceptions might also vary and how we might want to think about them when we think about care, which is quality, but also is something which is contextual. And we have now seen some interesting positive innovations also, I guess. So you have this example which was quoted in the New York Times. These are about individuals with lived experience of illness who are available for other patients during the care process. And they are available to tell them about what to expect, what does illness mean, how it might pan out. And this is an example of what Nura Health is doing. And again, individuals with lived experience who might act as therapists, coaches, friends, philosophers in helping other people cope through the care process at their end. There is also example of task sharing, other approaches where we have, one sec, just give me 1 minute. So confirming, can you see my slides now?
Yes, we can.
All right, okay.
Thank you.
So then task sharing, what is task sharing? Now, this is not new in the sense that we've seen this in our maternal, neonatal, and child health space. If you look at what was done with the Gadchiroli example and search, where again, workers from the community were trained at looking at neonatal mortality and sepsis, etc. And they were trained to identify and provide first level care. And that was shown as an example of how communities can address acute health situations. And learning from that, this has now been applied in a variety of other health conditions, including mental health. And hence, this has been also acknowledged as an important approach in addressing the mental health needs of communities. So leveraging community health workers to deliver interventions which are evidence-based using a task-sharing approach. Now, interestingly, this commentary in Lancet, based on papers which were published then, spoke about the fact that there are two ways of doing that. One, you might have health workers who are playing a designated role around mental health, which could be a part of a larger repertoire of work that they are doing, or they have a dedicated role. So they are community health workers who do mental health. And if in either of these models, what they found was that these approaches could be useful in addressing depression. But if you wanted to specifically address substance use disorders, then you would ideally need to go with a more dedicated role for community health workers. Now, of course, there is a cost attached to it. There is a need to recruit more people to do that specifically. So it's a policy question. What we've also seen is in India, at least, that we have one of the most progressive legislations in the health space, which is the Mental Health Care Act, which came into being in 2017, the rules following thereof, which talks about rights-based approaches, which talks about making services available and making health systems and governments accountable for providing that kind of care. But of course, the challenge always is in the implementation, as we know, but at least we have a strong legal framework. And then through the reform of the primary healthcare approach, so the comprehensive primary healthcare approach specifically focused on mental and neurological conditions as an important area of investment. And so in the package of services, you then see now a clear reflection that especially in our sub-centers now upgraded to health and wellness centers, or AAMs as they are right now called, that there would be screening happening, there would be community awareness, there would be identification and referral for care where needed. But some level of care being provided at the level of sub-centers as well as the primary health centers. And the kind of services that are already mentioned speak to this. Also, when the CVAC form, which is what is used by ASHAs in India, was revised a few years ago, there was a specific addition of PHQ2, which is kind of a screening, a pre-screening for depression specifically. And this was added again to encourage the fact that whenever there is at least CVAC based assessments happening in communities, that we would be hopefully able to pick up those individuals who might be struggling with depression or depressive symptoms, and they could be linked to care. So at least there has been that positive innovation happening where there has been a recognition for the need for mental health services. Of course, a lot needs to be still done. And also this has been something which large networks like the Self-Employed Women's Association or SEWA which have a lot of workers who are informal in informal workspaces. They have these models of working through women leaders in the community called Agevans, and these Agevans in many cases have been trained to do a variety of community health interventions and outreach. And some of them are now also being trained on community mental health. And we've been working with Seva in some piloting. But this is an interesting example also of organizations which are fairly large in terms of being networks, which have recognized the need to work through community link agents to address mental health. And if you look at the global scene, then you have examples like the Friendship Bench from Zimbabwe, where also it's an evidence-based therapy, a recognition that older people in the community might be available, they might be trusted to be able to provide care to those individuals who might be needing mental wellness interventions, who might be struggling with mental health. But again, the focus very much being on evidence-based, right? So this is not just any conversation, it's conversation based on a therapy which has science backing it up, right? So that's something, and now this is something which is being replicated also in many other parts of the world, including the US, where you have this kind of a path-based approach to, again, closer to communities where talk therapy, as it's commonly called, can be offered. In Gujarat and in Maharashtra, the Center for Mental Health Law and Policy has also been working with community champions and again, community level individuals who are trained to be able to identify individuals who might be struggling with mental health, link them to care, provide some kind of interventions to them, and be able to encourage them to access higher level referral care where needed. So again, an interesting model which has shown to have a lot of positive evidence, and now it's being scaled up in other parts of those states. In Jharkhand, Ekjut has been working with this very interesting model, especially with young people, youth, who are from the community, where support groups are formed, where there is community-based rehabilitation built in, where there is local languages which are leveraged for talking about mental health, where stigma and discrimination is addressed. And these individuals are called Sukh Dukh Ke Sathi, right? So even conceptually, they are seen as individuals who are with you, they are peers in the community, who are with you at times of both joy and distress, right? Which is, I think, a very interesting framing of how we might want to look at mental health and mental wellness. Now, coming to our work specifically in Sangath, what we've been doing is building a lot of evidence base. A lot of this work has happened by looking at health workers who are working in facilities, but also community agents, and trying to build a case for task sharing in mental health. And a lot of this evidence base has been published. And specifically in the Bhopal team, we've been working with Ashas in Madhya Pradesh. And the idea came through actually pre-COVID. But in many ways, during COVID, we also recognized the fact that because physical trainings became difficult to do that, how could we think about leveraging digital technology to be able to offer trainings, and then see if we could also use digital technologies to enable these community health workers to deliver psychosocial care and provide them supportive supervision towards that. So a lot of that involved a lot of human-centered design, co-production of approaches, and a lot of this has also been published as to how we did it. But initially there was a lot of concern that would, for example, digital training be possible? Would delivery of care be possible based on learning from digital learning management systems, etc.? And we saw feasibility, we saw acceptability. Now, also in working in many districts, we are seeing that this can actually also lead to provision of care. But of course, you need to have the safety net of support being available, supervision being available, and access to things like data, right, which is increasingly available, but there is a cost attached to it. So there is a possibility of also looking at how we can leverage digital tools as smartphones, as internet reach is increasingly becoming more and more common. Of course, there are caveats. I wouldn't say it's a perfect solution. There are large pockets where that kind of internet availability is not there, or there is a fair section of community health workers who might not be very comfortable with technology. And that, of course, needs to be acknowledged. So you need to have both models, perhaps in-person, face-to-face training and then follow-up, but also digital technology could have a role to play. And some of this evidence is increasing, as I mentioned, and here are some photographs from some of our trainings. So this work then now has been expanded. We started working with adult depression specifically. Over time, we have also started to focus on perinatal depression, which is another area where there has been a huge underinvestment and under recognition. So if you think of India's maternal and child health program, that's been there for probably decades now because of this focus on wanting to reduce maternal and infant mortality. But the fact that 1 in 5 pregnant women or lactating women likely is dealing with a mental health issue is just not acknowledged by the program. So there is no screening usually for perinatal depression or anxiety. There is no linkage to care. And this has clearly been shown in evidence to have poor outcomes, both for the mother and potentially the future baby. And just the lack of sort of response to that is a bit baffling. But perhaps ASHA workers could be part of the solution. And some of our work with ASHAs has revealed that this could indeed be true because, as you know, they were raised as a new cadre largely to focus on maternal and child health. And this feature in the Hindu spoke about how some of these ashas are bringing care closer to the communities in a way that it's accessible and addressing stigma issues, etc. Now, to support them also, of course, we try to address the demand side in a way, which is by increasing public engagement around mental health. So you'll see these kinds of wall paintings in a lot of facilities in Madhya Pradesh, which talk about the importance of mental health. We do a lot of outreach work with communities, whether that be in Panchayati Raj institutions, schools, colleges, chopals, where there are conversations around mental health. We have tried to redesign games like the snake and ladder game, the Saap Sidi game, to be able to again use that as an opportunity to have conversations around mental health, stressors, determinants of mental health. And while we've been doing this, sometimes we face this interesting question where ASHA colleagues would come to us and say, it's great that you're working with us and that we are trying to offer psychosocial care to communities based on the training and support you're offering us. But what about us? No one seems to talk about our mental health needs, our wellness needs as ASHAs, and we also have stress. We also went through a lot of, especially burnout and also stress around COVID, where sometimes we did not have access to masks or we didn't have access to gloves, etc. Why don't you do something for us? And this is something which is also globally acknowledged, that health workers, whichever level they might be in the hierarchy, also often face these challenges of potential burnout because of the kind of stress and the intensity of work that they have to do. So based on that, we started working with ASHAs. We designed a project which is now trying to come up with interventions which focus on mental health and wellness needs of community health workers like ASHAs. And this hopefully would provide some evidence around what could work when we are talking about mental health and wellness needs of community health workers like ASHAs. We have a randomized control trial which is towards its end called Anant, which is looking at positive psychology-based approaches. We also piloted the WHO self-care, self-help mod, SH Plus, as it is called, module for community health workers, and that work also we are hoping to expand. So I think in our mind also, of course, this is perhaps an open comment for everyone, that when we work in community settings, it's important to also look at mental health and wellness from the perspective of the care providers and their needs and try to design programs for them. Now, does this work all the time? Are there no challenges? Absolutely not. There are challenges. There are challenges around the fact that there are marginalized communities, and marginalization can be of various forms. It could be sexual identity, gender identity. It could be your caste identity. We have seen, and we've also been criticized, and for good reason, as a larger community in mental health, for the sort of silence around caste and mental health, and that being an important predictor in our society of poor mental health. But how do we also hence ensure that our providers are affirmative in nature, that they are able to provide services, counseling, psychosocial care, and support, which is affirmative in nature, which addresses the kind of stigma many of these communities have been historically facing, and understands that and does not actually discriminate based on that, but responds to the requirements based on that discrimination. And we did a series with UNDP a few years ago, which talked about how we can bring mental health closer to communities which have been historically marginalized, and what are the kind of elements of that, especially what kind of peer-based approaches can be used to try to respond to those needs. Now, a lot of our evidence generation involves working with health systems, but as I showed earlier, it's based on running these randomized control trials, which are in a very controlled environment. And we all know that you can establish maybe efficacy in controlled trials, but when you go to scale, when you're trying to establish effectiveness, that has its own challenges. And its challenges can be anything from who's going to pay for the incentives, who's going to ensure that quality is being followed, who's going to ensure that there are services which are being tracked, and how are you making sure that quality is being addressed, because the lack of quality can be a risk factor in mental health by itself, right? And so these are challenges which I think all of us need to think about, that we can have innovations happening in perhaps pilots or small scale, but when we are scaling up, this can be challenging, and there can be loss of translation and of, again, what is being available to communities could vary based on the kind of investments or the lack of it at the level of scale. So that's something I think all of us need to think about, because that's an important gap often. Because while these innovations are done in project mode, but they might wither out in the absence of sustained support after the project period, right? And so this long-term examination and understanding and an ongoing engagement with what is working, what is not working, might become a little bit difficult in some of these projects. So that's something I think is something that we think of a lot, but I'm sure in many of your experiences, whether or not you work in mental health, this is something you would think about. The other issue, and this might not be specifically only about communities, so we could again be very expansive in our definition of communities, but the fact that everyone seems to now be offering mental health, right? So you have Instagram influencers, you have celebrities, so folks who claim to be doing wellness or who claim to be offering mental health, but all of us need to be critically examining whether that is based in evidence, right? Because whoever is offering it, it's not really a matter of whether it's an influencer or it's a dentist, a homeopath, ASHA worker, MBBS doctor, but is there evidence backing what they're offering? Because poor quality interventions can actually be harmful and would lead to risk to the recipient of that kind of a care. And that's why we need to worry about the kind of proliferation we are seeing of care providers when it's not clear whether that is steeped in evidence or not, right? Now, another criticism we often face is, well, this is all nice, but you're working with ASHAs, and aren't ASHAs over? Everyone wants to work with ASHAs. You're bringing in another program working with ASHAs. Now they have to do mental health also. They are supposed to be doing maternal and child health. They are also supposed to be doing NCDs. They're supposed to be doing vaccination. In COVID, you want them to do screening. Now you want another program to be, piled up on top of that. So is that not unfair? And I think it's a good criticism, right? It's something that we think about certainly. What we've realized is that some of these approaches, while they might focus on offering mental health through ASHA workers or any other form of community health workers, what they also do is strengthen their approaches to dealing with communities. Because at the heart of offering psychosocial care are counseling skills, are community engagement skills, are offering a listening ear, are trying to understand what might be the psychosocial factors which are predicting the kind of situation that you're seeing in a particular member of the community who might be struggling, because it might be due to domestic violence, it could be due to financial precarity, it might be because of chronic illness, right? And all of those are important predictors of mental health, but also could be things which the ASHA could look at and try to find solutions for, right? So that's one. The second thing is many of them have recognized through these trainings and the supportive supervision which is built in, that at some point of time, they or members of their close knit family or friends or loved ones were also struggling with mental health. And they just had not been able to pinpoint it, right? Because the symptoms of anxiety or depression could be very similar to a whole lot of other things. You could be seeing symptoms which are similar to what you see in anemia or a whole lot of other common conditions. So the fact that many of them then said that I wish I knew this earlier. I wish I had been able to recognize this in my child, in my family member, in my husband, in myself that I was probably struggling with mental health, but I did not know that this was a Mansik Swastika issue, a mental health issue. And if I knew, then maybe I would have accessed care earlier. So there are some positive impacts of also working on mental health, which probably extend beyond just a focus on mental health, because in many ways it's a cross-cutting determinant, right? And it is mental health would apply to any form of health condition, whether you have sickle cell disease, TB, leprosy, a chronic condition, cancer, right? All of those would have mental health implications. So the fact that if we embed mental health training and mental health services in primary care, a lot of that would be useful. And also from a prevention and promotion perspective, if we are able to identify individuals who might be at risk, if we are able to offer mechanisms where people are able to take care of themselves and focus on mental wellness, then maybe that will also help address to some extent the burden that we talked about earlier. And that, I think, is another aspect where the role of community health workers becomes important. As I was saying earlier, ASHAs and other community health workers could also help us address some of these more hidden mechanisms of mental health as it sort of pans out. Perinatal depression, as I was mentioning, being a major area where there's not been a lot of work happening. We've been trying to do some work in around 8 to 9 districts of the state of Madhya Pradesh, where we are working with around 2,400 ASHAs, and the idea is to train them to screen, to provide first level psychosocial care, and link those pregnant and lactating women who need more specialist care with the health system. And the idea is to build a model which hopefully can be again scaled up and integrated into India's focused maternal and child health program, to be also recognizing this as an important need. The other example, important facet to working with community health workers is the work with people in vicinity who also often have lived experience. Many of the ASHAs themselves are also living the same social realities which other members of the community are living. They might also have faced in the past mental health related concerns or issues, or known someone in the community who has had that. And when you have that embedded lived experience built in, it does help, because it helps understand and provide the language for making that connection with someone who might be struggling. And so this focus on lived experiences in a way also a plus, which can be leveraged when we are working with community health workers. So in conclusion, if we look at policy, slowly we are starting to see a recognition for mental health as being an important area of response for the health systems. The Paro Declaration from WHO CRO, which came out a couple of years ago, focused specifically on what can be done in the Southeast Asia region. And they spoke about the need for transformation away from disease-centered approaches towards well-being, which is in many ways the topic for today as well. Moving away from a biomedical approach to something which is more social in nature, where communities are engaged, where we address stigma, increase awareness, improve access to mental health services, and try to shift the way in which mental health is understood, assessed, and treated, right? Now, this is all from the declaration. It's language which I think all of us should use in our own advocacy around how and what kind of mental health and wellness interventions we want to be rolled out in our communities and in our work. And just leaving you with some pictures from the work with ASHAs, ANMs. We've also found community health officers as another relatively newer cadre, where one of their responsibilities, as many of you will know, is mental and neurological conditions, and perhaps leveraging CHOs as another cadre who are working in community settings to think about how they can, especially focus on mental health, because that could be one area that they can build an identity around. And again, while there were a lot of challenges with working with digital technologies, we've also seen pluses in terms of being able to reach a wider number of community health workers. And many of them have ended up using the opportunity to get trained digitally, because they can do it in the evening, in the morning, during the bus ride back from their sector meeting. If there is internet coverage, sometimes we also make the apps operational offline, and at all points of time, they have access to support from project teams. So they've used it in various creative ways to try to learn and then use that opportunity to offer mental health interventions and wellness interventions to their communities. And that I think has been a learning for them and for us, certainly, which we are very, very grateful for, because I think only with their involvement and their leadership is the kind of work that we've been cataloging, which has come through now. And of course, towards that, we also offer aids to them. We try to make it much more user-centered in terms of booklets being available, in terms of manuals being available, which can help them understand at which stage of pregnancy, at which stage of mental health issue can they offer, what kind of services, etc. And so I guess one of my sort of takeaway messages for today would be that this is an opportunity. There are certainly challenges, but if we are to address the huge treatment and care gap that we see in mental health, which has been historically a marginalized issue in health system interventions, then we need to think creatively, and we need to think of ways where, given the stigma, given the fact that mental health is not considered a priority issue by both communities and policymakers, that we need to embed community mental health services, interventions with a strong evidence base behind it in accessible ways in communities. And perhaps community health workers, community agents, community leaders, community youth, all of those could be mechanisms where, if they are offered training, if they are given the support, when we ensure that this is evidence-based, we might start chipping away at the kind of a mental health burden that we were seeing and we continue to see in mental health. So I hope that was useful in terms of sparking off a conversation. I look forward to your comments, questions, and thank you again for the opportunity. Back to you, Anand.
Thanks, Anand. That was a very thorough overview, I think, of the sort of the landscape in the condition of mental health in the country, and sort of the possible solutions that are already on the ground and have the potential to do more. So thank you for that. And we already have a couple of comments about ASHA workers and so on. And I urge our attendees to put questions in the Q&A box. Anand's here to answer as many questions and engage in a discussion for as long as we'd like. But I'm just going to start off with a question. Can you tell us a little bit more about the content of the training? Like, these apps look really interesting. And what kinds of things, what kinds of skills are ASHA workers taught? And how long does the training typically take? How do you overcome, you mentioned yourself that, stigma is sometimes difficult to overcome. How do you educate, or how do you train ASHA workers to overcome those issues, both within themselves and with respect to the communities they work in?
Thanks. So a lot of this training has been iteratively developed. Idea has been to leverage science and evidence base. So, for example, some of our programs are the Healthy Activity Program or the Thinking Healthy Program, peer delivered. All of them have a certain theory of psychology and psychosocial care behind it. Behavioral activation is one form of therapy. But to make it accessible to ASHA workers, there is a whole development of the module, in terms of how this could be something that is easy to follow, easy to understand. Now, typical face-to-face training for adult depression based approaches is somewhere around 6 days of face-to-face training, not very different from the usual modular training that they have. And so, of course, but there is a cost to that. There is the requirement for them to be coming 6 days back to back. And so we've tried that as well. And if the health system supports them, which is usually possible through buy-in, then we have seen many of them come. And in, of course, the face-to-face training, you have mechanisms about reflection, about a lot of role playing, about starting about broadly about what is mental health, what is symptomology of mental health, why do we not consider it important, what are the kind of stigma issues that we have. There is content around counseling skills, right? So there's a whole set of modules around counseling, a recognition of how to do screening for these kinds of mental health issues, how to offer counseling, learning the counseling stages, right? These are typically sessions which are 6 to 8 sessions, for example. for depression. And then you also need to know how to know if they are making progress, they're not making progress. If they're not making progress, should you be referring them up the chain, right? So all of those components are taught, and it's absolutely the case that, as is true of training any health professional, whether that be an ASHA worker or whether that be a super specialist, you cannot just train and let go, right? You need to offer the supportive supervision post the training, where if they start delivering care, then you have to ensure that there is quality, that there is a mechanism to be able to understand whether they are following the science, whether they are asking the right questions, whether they're offering therapy in the right way, and are they covering the right bases in terms of what needs to be covered for each session. So a lot of the models that we use involve that supportive supervision and hand-holding, because in the absence of that, as I said, you could very quickly lose what you've learned and end up offering half-baked care, which is not really useful. So ensuring that they're covering the key elements of care becomes important. And that's where there is a certain level of hand-holding which is built in. We've tried to digitize that as well, right? So we've had models which are purely face-to-face based. We've had models which are purely digital in nature in terms of the training, again, with digitizing all of these elements. And we've also had models which are digital in training, but then there is a coaching element built into it. So a coach who meets regularly, almost on a weekly basis, with the ASHA workers and discusses what they have learned in that week of training digitally. Are there any concepts which are not very well understood? Would they like to revisit the key concepts of training, etc.? And some of that evidence we will be probably publishing soon as well. But again, we've largely found that digital training, especially with some element of coaching built in, can have similar competence outcomes to face-to-face training. So depending on what model would work for a particular health system, we could look at all of these options, but it's extremely important to make sure that it's grounded in science and that there is supervision and support offered, right? You cannot just do training and assume that next day suddenly psychosocial care is available in the building. That would be a faulty precept. And sometimes I worry about that because we get approached to do trainings, sometimes by organizations, and the assumption is you can come in and do a 1 or 2 day orientation, and then next day you're good to go. And I don't think that's how it works. As is true of many other forms of care, you need to ensure quality is centered in the way we approach our trainings and follow up. But of course, training, taking that to scale has its own challenges, as I was referring to. And how do we ensure that happens will require some more critical thinking.
I think it's really important, as you point out, that our approaches to training have to be this very multimodal sort of approach, digital, face-to-face, a combination thereof, working with different cadres of health workers and so on. I think that's key to point out, which actually brings me to another question that's in the, by Thirumalai Narayanan. He asks, how do you measure the efficacy of these programs? What kinds of mental health outcomes are you measuring at the individual level, at the community level? Can you tell us a little bit more about that?
Sure. I mean, so there are various ways of knowing if things are moving in a direction that you want them to move into. For example, you look at competencies. So there are skill-based tests that we use to understand if the skills that you want or the competency that you want from the training is something which has been acquired. And so that focuses more on the competency based on the training. When you're starting to work with individuals in the community, let's say someone with depression, then the score which is used, because the screening tool for depression which is used, let's say a PHQ-9, gives you a certain score, and that is one way of knowing if a person at some point of time has a certain score, and if you do provide therapy and then you do another screening, if the scores are going down, then of course it could also be organic in nature, right? In placebo, there's a placebo effect as well, but it could also likely be that the counseling, etc., is helping. And so using evidence-based approaches again to do screening, and there is a variety of tools which are used. PHQ-9 is just one example. You have tools like K10, which are also inclusive of anxiety, etc. So looking at both patient outcomes as well as competency outcomes is one way of approaching it. You can also look at larger, more health system outcomes, which would look at how is this probably also helping improve care at scale in other forms of health system interventions, but that would require slightly more expansive health system evaluations, right? Most of our work will focus more on competency and the patient outcomes, which are of interest because that tells you whether the therapy is working or not.
Thanks. Okay. I think each of these questions leads to a number of other questions, answers leads to a number of other questions, but several questions here. Arushi asks, in a lot of communities that there isn't often the language or the vocabulary or the conceptual framing around mental health issues. So how do you address that? And I think she answers the question a little bit by saying by working with the communities. But given the real world constraints of working with communities like limited fundings and tight timelines and so on, how do you ensure that these interventions remain culturally sensitive and sustainable over a long period of time?
Yeah, no, great question. I think in our work also we try to sometimes identify that lexicon or the language which is used. So in some communities they will say tension. In some communities they will say stress. There is not like no one uses depression, obviously, right? But they will say कि काफी टाइम से टेंशन हो रहा है या फिर घर में समस्या है तो उसके कारण से नींद नहीं आती है. So you look at then the symptoms of what could represent something which could be linked to depression or anxiety. And it's important to pick those up because if you just go by a very textbook definition of what you have to ask and what the symptoms are, then you will likely miss out. And we've also seen some cultural variation. I see in the Q&A also there is this question around Adivasi communities because the way communities respond to stressors, there is sometimes when you could argue a little bit of resilience, but perhaps again it's just that there's been just this chronic onslaught of stressors that there is a certain a response which they have built over the years where they don't identify that as something which worries them because that's how they've lived their lives. But that doesn't necessarily mean that they're not not needing mental health support or interventions. It might just mean that we need to think about redesigning our approaches to understand what is happening and what would be a contextualization or adaptation which is needed, which works in that particular setting. And so what would work in a peri-urban area of Bhopal would be very different from what would happen in Dindori or Jhabua, which are primarily tribal. And so in our interventions, which are also multi-district, we sometimes see that your same tool might not operate in the same way. And then you need to dig deeper and try to understand what exactly is happening and try to learn from that and maybe again try to adapt. That having been said, there's been a lot of work which has happened with communities, tribal, rural, semi-urban, marginalized, to try to understand mental health. And so that evidence and that experience can also be leveraged. But certainly the case that language around mental health is sometimes more local in nature and we need to understand. The other example of that, which sometimes gets a bit controversial, is what is the role of faith healing, right, in communities? Because, when you talk mental health, a lot of communities, people will say, वो लोग तो दरगाह जाते हैं या झाड़ फूक कराते हैं और जब बहुत ही ज्यादा समस्या बढ़ जाती है तो वो जाके फिर सोचते हैं डॉक्टर के बारे में, right? So they go for faith healing, they go to a local place of worship, and only when they have symptoms which are really acute do they think of going to a health facility. Maybe there is a middle ground, as has been tried out in some parts of India, where you have programs like Dawadua in Gujarat, where the idea is if spiritual approaches, healing gives you some level of comfort, you encourage communities to do it, unless it is violating your rights in some way. For example, if there is violence involved, right? Or if there is incarceration, people are being chained up or people are being beaten up, then clearly that's not acceptable, right? And we, of course, none of us wants the repetition of the kind of tragedies we've seen in the past, with the Erwadi tragedy being one example, where persons with mental illness were chained near a spiritual healing venue, unfortunately died because they burned to death. There was a fire and they could not escape, right? So we have those kind of violations in the past. We have had forced interventions which have been where women with mental illnesses had mass hysterectomies in Maharashtra. And there was a whole response by women's health activists questioning that, saying that just because someone has mental illness does not mean that they don't have agency, right? Or they don't have choices, and they have a right to sexual and reproductive health just in the same way any of us has. So there is a whole history of violation in mental health in India and many other parts of the world, which is where I think, again, it reminds us that whatever we do still needs to be centered around the rights of those with mental health illness and their caregivers, and that right and that agency should not be taken away. But we need to find mechanisms to make them more aware of their rights and support them in their healing journeys. And that's where I think community health workers can play a role. This does not take away from the need for specialist services where needed, right? None of us are going to argue that everything can be done at the level of the communities and ASHAs are the solution to everything. There will be individuals who cannot benefit from the kind of psychosocial care which is offered through task sharing approaches, but that might be a subsection, a relatively smaller subsection. The vast majority of individuals could benefit from community mental health interventions.
I think several more questions sort of unpacking what it means to address members of the community. Suraj asked, for instance, what has been the participation or response of men from these communities? Especially they're largely delivered by ASHAs or in the context of maternal and child health. Do men? I mean, we know that even within the mental health crisis, there's a very big gender difference as well. So, can you reflect a bit more on that as well?
Yeah, that's something we've thought about a lot because, and there are, I would say that there are some challenges there as well, because in some of the communities, again, the Asha is often, as many of you know, called the Bahu of the community, right?
Mm-hmm.
She is usually a daughter-in-law, and often, again, the Asha, the choice of who becomes an Asha is also sometimes political, right? And she might come from a relatively more privileged background, caste, or socioeconomically within the community, which also means that sometimes she might not go to certain households in the community, or if she is from a less privileged background, that certain community households will not welcome her. They'll keep her at a distance, right? And those are the social realities in which ASHAs operate, which is not specific to mental health, but of course also will impact their ability to offer mental health. Then there is this additional element, which is a very valid question around how do we then engage men, right? Isn't there a gendered aspect? By only largely working with ASHAs, are we potentially losing out on men who need mental health? And I would say it's a sort of a mixed bag. We've discussed this sometimes at length with ASHA workers. It seems to be the case that many of them have been navigating that paradigm for quite a while, right? Especially the older and more established ASHAs, because even to be able to convince households about doing antenatal care regularly, about institutional deliveries, etc., they have had to navigate these dynamics at the family level and be able to work with men in the community as well, whether those be father-in-laws, husbands, brothers, etc. Right? And so they have learned to be able to speak and manage that and do that in a way which is tactful, right? Because of course they have to continue operating, and so many of them say yes, it can be a challenge, but we find ways to have those conversations. But maybe not everyone is being picked up. Not everyone is comfortable with the model, which is where I feel that having perhaps more approaches, and CHOs is one good example because CHOs can be both men and women, unlike ASHAs. And CHOs are largely also increasingly available, especially in rural parts of many states like Madhya Pradesh. CHOs could be another resource who could be trained. There was also a question in the chat around how do we train, for example, medical officers in primary care, and what kind of models would you use? So the WHO's MHGAP is an approach which focuses on exactly these kinds of issues. What are the kind of training needs and capacity that is there needed for a medical officer offering primary care in mental health? What is the kind of training they can offer? What is the kind of screening tools they can use? How can they deliver services? And many of that has been adapted into our CPHC approach. Many of that has been leveraged by organizations such as ours in terms of doing trainings for medical officers so that they are able to also know. No, because what we see is that you might have, for example, medication available for mental health in the essentials drugs list, which means that it should be available at a primary health center. But providers are, for some reason, skeptical about doing mental health. So they don't screen for it, they don't offer care, they just refer out, right? If they have any inkling, which is also rare because they don't screen and they're not keeping a eye out for the potential comorbidity with mental health, that probably mostly miss out on it. But if they have this feeling that someone might be struggling with mental health, they prefer to refer out rather than manage at the level of primary care. So some of that also is important. So I think ASHAs in isolation is not going to be the model, or any kind of a community worker or community agent or community level individual. It has to be part of a larger system of access to care, and ASHAs can and should play their role, but it cannot be totally reliant on ASHAs. It has to be supported by a strong backup, whether that be at the level of the CHO, the medical officer, the district mental health program, where you can have screening mechanisms, as well as the linkage with tertiary care institutions. Now you also have Telemanas, which has been rolled out nationally, where counseling is available, linkage to care is available. And, again, I think they've been getting a lot of calls, and there have been some positive examples. It's relatively new. There is a need, I guess, to understand that better from an implementation science perspective, what's working and what needs to be improved on. But at least we have access to all of those mechanisms where, if they're uncomfortable speaking to an ASHA worker, but the ASHA worker feels that this might be a male individual of the community who's struggling with mental health, maybe linking them with the CHO or encouraging them to access Telemanas and call and get counseling services might be ways to address it. But that's a good question to ask, because we've also been thinking about how do we respond to those kinds of circumstances.
I think in your answer, you also briefly mentioned the challenges, not just with respect to gender, but also with, caste or other sort of discriminatory, marginalized groups within these communities. So what does it mean to provide community-based mental care in the context of communities where there is a lot of exclusion that goes on? And given that the care provider, the ASHA worker, is often from that very place, as you said, you already spoke about the instances of, where ASHA workers might not visit community members and vice versa. So how does one, or how have you, or how has Sangath gotten around these concerns? These are often the trickiest things to deal with in the field. You want to be culturally sensitive, but at the same time, want to ensure that services reach those who need them, right?
Absolutely, and I don't think any of us is perfect at this, quite honestly, Abha. I feel this is a gap generally in mental health broadly. The silence around issues such as caste, whether that be in tertiary care institutions where unfortunately we've had losses of young lives, both in medical colleges as well as universities. And many of us have been very troubled by that. But it's just sometimes the fact that we don't talk caste when we talk about health, right? And that's true in many ways of mental health as well. It's changing. I think there is now more scholarship and more advocacy, as well as more evidence being built around it. And that hopefully will bring about change. To your specific question, this is something we do discuss sometimes in our trainings. And ASHA Didis, ASHA colleagues also often speak about this, that they face discrimination if they are from a less privileged caste, and that they might not be made to feel welcome. This is not unique to mental health. This is how maternal and child health also operates. There are ASHA colleagues who talked about the fact that community members will speak to them from the parapet of their house, but not invite them in, right? Or that there are certain community hamlets where ASHA workers might not go or might not go regularly, because those might be of relatively less privileged caste background households. And that's the social reality, right? So part of what we try to do is to discuss that in a more open, transparent manner and talk about their role as members of the community who are there to offer care to all sections of the community. But I wouldn't claim that that necessarily changes the paradigm in any significant way. And that's why even in my when I was presenting the slides, I talked about the fact that there are certain areas where we can all do better, and certainly caste is one of them. Because I don't think we've gotten it right, and we need to find better mechanisms to both communicate and address that also as a social determinant and as a factor of poor mental health, because that leads to violence, that leads to discrimination, and there's a whole lot of social implications which have clear linkages with mental health as we know it.
Yeah. Yeah, tricky area to work in, and in all sorts of public health spaces, not just with mental health, right? So there's a few more questions sort of about the logistics of the, the work that you do itself. So Pratishta asks, does digitizing modules leave space for, including the community health workers' knowledge and lived experiences of being in the same community? I suppose this is about sort of the standardization of the tool, and what do you lose by that, perhaps?
By having digital approaches, is that the question?
Yes, I think the digital tool and the fact that it becomes a standardized sort of training and tracking and monitoring mechanism. There's lots to gain, obviously, but what is lost in that transition as well?
Yeah, I guess the conversations could be lost because a lot of the training is about the conversations and the community building. Because in many ways, a lot of these are based on peer-based learning approaches, and even the delivery of care does leverage the strength of the peer community. So a lot of the follow-up is about creating those smaller groups which offer feedback to each other. So you might anonymize counseling sessions and then say, okay, on rotation, we will listen to a recording of a counseling session. We do that in some of our follow-up. And then let's just provide feedback. What could you have done better? Did you cover all of the requirements of that counseling session in terms of how you started, what you focused on, what you discussed, what you encouraged the other person to share, what kind of support mechanisms and interventions you offered? So, as I mentioned, the training is only one component. You have to build that supportive supervision and supportive peer support mechanism as a part of when they start delivering care, because that's when the actual therapy happens. The learning is only one component of that. That having been said, even during the training, it's always the case that the trainer is available in case there are questions, in case there are doubts. It could be the fact that we lose out on certain elements of face-to-face interactions, but there are pluses as well, right? The fact that more Ashas are able to do digital training because it's difficult sometimes for them to be able to step away for 6 days back to back because of their family responsibilities, social responsibilities. Many of them are young mothers, or or this training might be happening during the agricultural season when they are supposed to be also working with their families and doing the cutting of the crops, etc. We've seen all of that play out. Or there is an acute illness in the family, or there is the need to accompany a pregnant woman for institutional delivery. So then face-to-face is not feasible for many of them. Some of them, it works out. Some of them come for 2 days, don't come for the rest 4 days. Some of them will come for 3 of the 6 days, right? So there is always that loss. With digital also, it's not the case that everyone finishes it within 2 weeks, 3 weeks. Sometimes you have to follow up and extend the time, and you have to coax them into doing it. But at least there is that space of doing it at their pace, at their time of choosing. If that's the evening when they've finished off their regular work and they have some time before dinner, etc., or if they prefer to do it during the day when there is a breather available early in the morning, or during their bus ride to the meetings, etc. It's their choice. But you always have to build in that additional element of providing support to them. And that's where some of these conversations can be there. But that's a slightly resource intensive model. See, that's why I kept saying that, in project mode, many of these mechanisms are possible. But when you are thinking about scaling it up at a health system level, then how much of that will be retained is a question mark. Because even routine ASHA training, a lot of that follow-up is there in some ways, but is also not there, right? So that's where I guess the ASHA supervisors, the community mobilizers, the block community mobilizers, the district community mobilizers, involving all of them also to have the capacity to offer support, because you can't just train ASHAs and not train others in that whole chain, right? Because they need to know what to offer in terms of support. Right. So, then that would be a design flaw if you only work with ASHAs but not the support mechanisms within the health system who supervise, but who are also supposed to be offering support to him.
I think this your response actually ties to another question, which is about the monitoring and evaluation, especially in geographically distant areas or where there's very large communities that the ashas work with. And Chetan asks, how best can we ensure that there's feedback mechanisms and so on. And I think you just gave the answer, which is that you cannot work just with ashas. You have to do training of those higher up the ladder as well, the CHOs and the DHOs and so on. And to ensure that all of them are looped into what the training entails and what kinds of outcomes you're looking for and so on. Is there anything else you would add to that? I think you've spoken a bit about the challenges of sustaining these programs over a long period of time. But if there's anything you would like to add, this is a good chance to unpack that further.
Yeah, no, absolutely. I think strong monitoring, evaluation, and feedback mechanisms is absolutely important, because as we expand, then ensuring that fidelity and quality is still there and that care is being offered, screening is being done properly. Because poor screening has, both positive risks and negative risks, right? You don't want people who need to be identified and provided care missed out, and you don't want people to be unnecessarily put through an intervention when they might not need it, right? So doing the screening right, knowing who needs to be offered care, offering that care with quality, because if it's just a tick box that I did a counseling session, then we've seen also in some of our work examples where the counseling session, because we track how long the counseling session is, sometimes we make them also recorded where possible. If the counseling session is only for 3 minutes, 5 minutes, when the average counseling session should be somewhere in the range of, let's say, 30 minutes, 40 minutes, 50 minutes, then there is something problematic, right? So we might go and look at or try to listen to that session to try to see what happened exactly, right? Was it just, hello, how are you? I'm here for the session, and then just some chit chat and stopping? Or did they actually focus on the requirements of that particular counseling session? And all of that then feeds into trying to understand where the gaps might be, where quality might not be maintained, and then do corrective actions accordingly, which is true of any health system intervention, right? Unless you ensure quality is maintained or fidelity is maintained, then you're going to lose out on the kind of outcomes that you want, clinical and public health. So that is an important part, because ultimately these are being offered at community level. So monitoring and figuring out monitoring mechanisms which could work, especially at health system level, would be important. We try to do it by offering that support and supportive supervision, and also the peer support and peer supervision, and that helps to some extent. But again, more evidence and more work needs to be done to see how this could be further refined.
Have you, several comments by Dr. Anthony Colonur in the chat and so on, reflecting on ashas and how best they can be trained. And I urge the attendees to read some of his comments, which give some context for, the training that ashas are provided and what potential they have in these communities. I guess one way to look at the effectiveness of the interventions has been, has it actually reduced, as you said, the task sharing, the task shifting, has it actually reduced the, actually that's not the right question to ask, but are fewer people in need of services reaching, the few psychiatrists or psychologists who are available? Do you think that a lot of basic health, mental health issues are successfully being addressed at the community level?
So that's a good empirical question. I don't know if there's a perfect answer to that, to be honest.
Very hard to measure, obviously, that.
It is a bit hard to measure, but it's also the case that there is so much under the tip of the iceberg that we really sometimes don't have a very good sense of what was earlier being missed out, right? It would be likely the case that if this is scaled up and became integrated, that you would start to see those elements, that people who needed perhaps psychosocial interventions which could be delivered by a community member, they would stop needing to go to a specialist. But it's the case that these individuals are not going to a specialist right now, largely, right?
Correct,
it's only largely people with overt symptomology or with serious mental illnesses that are going for various reasons. One is the stigma, two is the lack of recognition that this might be a mental health issue. Three is the cost of either therapy or going to a psychiatrist, right? Both counseling from a clinical psychologist in private care or going to a psychiatrist could be fairly expensive, right? Because this is also this is not like getting a course of antibiotics for a bacterial infection, right? Typically, mental health therapy is also slightly longer and will require quite a few sessions in some cases. And so there is a lot of attrition. There is a lot of loss of follow-up, and that can also then exacerbate sometimes. What we know certainly from science is that if people are not identified early, especially individuals in their childhood and adolescence, if they are starting to have mental health issues, if they are not identified and provided care on time, that is likely going to have a lot of more chronic and more extreme implications from a mental health perspective. And as it is, we know from evidence that, for example, young women between 15 to 29 years of age in India, suicide, unfortunately, is among the leading causes of death, right? And so there is that clear linkage with perhaps the risk factors not being identified early enough. So in many ways, I think this is also part of understanding and contextualizing what would community health and community mental health look like, which integrated prevention, promotion, early identification, and linkage to care. Whether that linkage to care is at the level of the community or higher up in the chain would differ from individual to individual. But at least more awareness and understanding of mental health at the level of community care provision would perhaps mean that we had more early recognition and more early provision of care, which could also then lead to better outcomes. So that's something I think we will need a little bit more time and more availability of some of these experiences. As I said, many of these are innovations. They're not yet at scale. Some of these are slowly getting at scale, but we will have to wait a little bit more to know the impact at the level of public health.
Yeah. And I think your answer also.
Because your request is a fragmented.
Okay. I mean, it points also to the communities that are not yet served by the programs that Sangath has or the government currently offers, such as those for perhaps men, as we were speaking, or for adolescents, as you were just talking about. Aparna asks, I think this is a good suggestion in terms of broadening the spaces in which one can offer mental health support. She gives the example of how Black Americans in the US, often barbershops have been used as an intervention point, or in Australia with woodworking, community groups. So she asked, have there been any such initiatives in an Indian setting?
Yeah, I think many of the examples I was alluding to, so the Ekjut example of working with members from the community and also peers, right? So young people helping other young people. A lot of this has been tried out by members of queer or trans community, where members of the community are trained to be peer counselors or peer providers, with the idea being that they have a better sense of the lived experience and health needs. And so that those are examples. Atmiyata in Gujarat and Maharashtra has worked with community members, community champions, and then linking them to the health system as required. So Zimbabwe, the friendship bench is another example where members of the community. What you need is individuals who, one, are willing to offer a listening ear, who are put through a standardized evidence-based training program, and who are offered support to be able to deliver care and be available to their communities. If we can do that with members of the community, whether that be ASHA workers, whether those be community champions, whether that be Panchayati Raj institutions, whether those be young people in the community, who will also understand the need to ensure privacy, maintain confidentiality, be cognizant about stigma, right? So all of those are important factors. But if you choose the right people, then of course, any of these examples could be applied. And whether those be the women leaders in the Seva example, or it be, the champions from a village in Gujarat, or those be young people in Jharkhand, all of those could be people who can be bringing the difference in community mental health in their communities. And so all of these are very interesting examples of culturally adapted models of care, and again, with the evidence base behind it, because it's not, you could potentially benefit by having a good conversation and sometimes just the fact that you manage to get out of an oppressive environment at home and spend time in a barber shop or in a community meeting, or in a chat in the evening at the local water source. All of those could potentially be positively impacting your mental health. But it's not necessarily evidence-based in the sense that if you have a clinical need, are you able to offer that? I think hence requires the formal training and support to ensure that whatever is being offered is based in some kind of science. So that I think is the important part.
Okay. Thanks, Anant. I think I'm just going to wrap up with one last question here. We've been speaking a lot about the specifics of ground level interventions with community members, and to take a zoom out widely and ask, Arushi asks, how effective has Telemanas been in addressing the mental health care gap, which is about as distant from the kinds of community-based programs that we've been speaking about?
So, Telemanas is a good question to ask because I've been wondering the same thing, right? Many of us work, it's certainly the case that it has helped with more awareness around mental health, with more counseling being available in an accessible format. Now, it's not the case that there was no telemental health earlier. There was telepsychiatry, which was happening earlier, still is there in certain parts of the country. But here you have a national program which is being innovated at some level in the states also. So I would say that there are certainly benefits of Telemanas, but what is needed, and this is something I've spoken with colleagues in the health system as well, is perhaps more implementation science and health systems research to understand what is working well. Because whenever you have this kind of a model which is being implemented nationally very quickly, then understanding what is working, what is not working, what needs to be adapted, and where the gaps are becomes important. Because one also hears of some challenges with Telemanas gaming the system, sometimes providers not being available, and also not offering therapy in the right way. But these are anecdotal, right? And I don't think anecdotes can be considered evidence. If we did a more structured evaluation or looked at it from an implementation science perspective, we would probably understand better. But in my experience, at least, there is more awareness. There are a lot of health workers and health professionals who know about Telemanas. There is posters. There is, I think recently some states have also seen a fairly decent number of calls being made as well. In Madhya Pradesh also, I think recently they crossed a milestone number, etc. So it's clearly the case that Telemanas has led to an uptake of reaching out, which is great. That having been said, I'm sure there are gaps which can be identified and improved on. So that's again, I think it'll be nice if the health system encourages more implementation science in that area, which is true of all of us. As I said, none of us can also claim that our innovations, as much as all of us are fond of them, are necessarily always working, right? There are gaps in all of our models. And that's where I think having a skeptical eye and sort of always looking to see where we can improve is always a good step for all of us who are in the field of health or science. And so, yeah, I think it's a positive, new available intervention, but in isolation, it cannot solve everything. It's part of the chain of things we need in mental health.
It's another tool in the big toolbox that we need. So thank you, Anant. This was wonderful. I think thank you for engaging with all of these questions and providing thorough answers. And I think we've giving us a really good sense of what the real life scenario is, what the approaches are, what's working, what's not working. This was wonderful. Thank you so much on behalf of the Ramalinga Center for your time and for being here today. We really appreciate your talk, and thank you to all of our attendees as well.
Thank you. Thank you for the opportunity, and thank you everyone for joining in.
Yeah, thanks. Bye-bye.